Okay, now we're going to go on with the next module, talking about the male breast. And in this section, we're going to talk about assessment of benign entities. And there are very few cases of cysts. Cysts don't very often occur in male because they're more a disorder of the lobules in the breast. And women, as we know, have breast lobules, and cysts are very common, but men do not. So cysts are actually very rare in males, but occasionally we'll see one. Lesions of the skin are very common and similar to those in women. Sebaceous cysts and lipomas are very common, and they look the same. Abscesses and other kinds of infections we do see in males, just like in women. These are usually clinically apparent and treated the same way. Obviously, men will have trauma. More often now, we're seeing cosmetic procedures being done in men, so we see the attendant complications of fat necrosis. And lymph node abnormalities will occur in males as they do in females. But all of these conditions that I've just mentioned here appear similar to the way they look in females, so we're going to work them up on imaging. Similarly, you don't need any special techniques. We don't see this much in this country, but in other parts of the world, parasitic infections are very common, of a common benign affliction in breast tissue. Obviously more often in females than in males. This is an example in a female. I don't have one in a male, but if you happen to do a mammogram in a male for another reason, say a lump that's a cancer or gynecomastia, you might see evidence that there has been a previous parasitic infection like loiasis, and you might see these calcified evidence of the worms and the inflammatory response. It can only be tricky sometimes because the linear calcifications, if they're not serpentine like this, might look like linear calcifications of ductal carcinoma in situ. You would want to try to make a differentiation there. This is an example of a 45-year-old male who underwent silicone injections and developed a palpable mass where we see the triangle here. The triangle is taped on the skin to indicate the location of a mass, and all we see mammographically is all of the silicone globules. But on the ultrasound, we can see there's a small collection here, an anechoic collection with a sharp back wall and some enhanced through transmission, and you could call this the mini implant sign, just a collection of silicone that has been injected before it has become a granuloma. So we see this more commonly in men now than we used to. This is a 30-year-old male with mild gynecomastia. He came in to us because the clinician palpated a mass on the right in the 9 o'clock position where there is the BB, which is here, laterally on the craniocaudal view, here, laterally in the 9 o'clock position on the MLO view. And the patient complained of a lump that he thought he felt at the 3 o'clock position, which is where the triangle is. So here, medially on the craniocaudal view, again, this would be medial on the craniocaudal view. We don't see a lot of obvious findings here, but we're going to do some additional views in the lateral area. The medial area ended up being nothing of interest. It was just prominent costal cartilage. But I'll show you some more pictures of the 9 o'clock lesion. Here we have the magnification compression views, and we see mild gynecomastia under the nipple, but we also see this small mass, which looks like it's a little bit loosened in the center. Maybe it's a lymph node. The cortex is a little bit irregular though, not nice and smooth. So we do an ultrasound and we see a very nice normal lymph node here with the thin 2 millimeter cortex and the nice hilum here. So this is a normal lymph node. Same way you would evaluate in a female. If you saw these findings, you would call them benign. So we're going to call these benign. Okay, other benign things that we could see in males, these are going to be lesions that result from stimulation of ductal tissue, because remember, males have mainly ducts, not lobules, and the stromal tissue. Sometimes we see lesions that come from the stroma, but not lobular tissue. So we occasionally see a papilloma, because papillomas grow in the ducts. We can see diabetic mastopathy, which will be a process in the stroma, and also PASH, or pseudo-angiomatous stromal hyperplasia, PASH, which is a condition of the stroma, which is benign. So we see these in males. More rarely, we will see other benign tumors like granular cell tumors and myofibroblastomas. So this is an example of a PASH. This was a little boy I saw, a 13-year-old boy whose complaint was bleeding from the nipple. And when he first came to the clinic and the technologist told me I was going to ultrasound a 13-year-old boy with bleeding from the nipple, I said, yeah, right. Well, he actually had a lot of bleeding, so much that it wouldn't stop, and it was pretty much bright red blood. So he needed to have surgery just to make it stop. And upon excision, they found that he had pseudoangiomatous stromal hyperplasia, or PASH, with a little bit of gynecomastoid changes that you might see in a pubertal boy. So a rare condition in a boy like this, but it happens. This is one of my favorite cases. It's an old case. You can tell the old slide with the wax pencil marks, but this was interesting because this was a bullfighter, and he was gored by a bull and had major trauma to his breast here. He had a hematoma with fat necrosis at this time, and then a few months later it got better, but he still had a little lump in this area. So we did a follow-up mammogram, and now you see there's just this kind of thin rim of density with the lucent center. So this is now evolving, a hematoma which has evolved to the condition of an oil cyst. This does not look like a cancer. It's not denser in the center. It's fatty. So this is classic for an oil cyst as a result of trauma. So we're talking about other benign causes of abnormalities in the breast, and I mentioned granular cell tumor. This is from the internet. I've never actually seen a case myself, but we see here a mass on the mammogram, and sonographically we see a hypoechoic but solid mass, oval shape. Is this definitively a granular cell tumor? No, it's very indeterminate kind of appearance, very nonspecific. If this was a female, you might think fibroadenoma, but it's a benign tumor, but you would have to do biopsy to confirm that. Could it be a breast cancer? By the way it looks, yes. These are tissues which are typically of neural origin and more commonly seen in the skin and the mouth, but every now and then we do see them in the breast. Similarly, myofibroblastoma is a rare but benign tumor. Again, this is from the internet because I've not actually seen a case in all of my years. But here we have a nice, smoothly marginated mass under the nipple. Sonographically, you see that it's solid, oval, circumscribed, fairly benign features. But could this be a breast cancer? Yes, so it goes to biopsy, but is shown to be a myofibroblastoma. These are a little bit more common in men than in women, but look just like fibroadenomas would look in a female. Okay, now we're going to talk about carcinoma in the male breast. We've talked about the benign things that happen, gynecomastia being the most common, a few other benign conditions, but the most important thing, what we really worry about, is cancer, so we're going to talk about that. But remember that this is going to be rare in males. The incidence is 100 times less than that in females. And we only see cancer in about 3% of the males that come for breast imaging. It's worth remembering that the peak age of carcinoma in the male breast is 5 to 10 years later than that in the female. Why would that be? Well, it's because we don't do screening in men. The chance of men having breast cancer is so low that it is not worth doing screening. So once we do find a cancer, it's usually because a cancer has become large enough to palpate. So we see them when they're slightly later and also slightly more advanced. How does male breast cancer present clinically? Well, it's usually a painless, hard, fixed mass. Usually they're subareolar. Occasionally they can present with nipple discharge, bloody nipple discharge, but this is rare. Much more commonly they present as a mass. They will present with axillary adenopathy more often than cancers with women, 50% of the time, but again, that's because we don't do screening, so they are going to present slightly later. Also, because the male breast cancer presents usually right under the nipple, they have rapid access to the lymphatic plexus, the Sapi's plexus of lymphatics, which are rich around the areolar area. So this is where the tumors occur. They rapidly can metastasize into the lymphatics and out to the axilla. What about staging of male breast cancer? The staging system is the same as for women. So for comparable stage at diagnosis, the prognosis is going to be similar. The staging system is the same. We talk about tumor size and node status. So that's all the same. All right, now we're going to turn to mammography of male breast cancer. It's important to remember that calcifications only occasionally present as part of male breast cancer. If we do see calcifications, it generally means that there is ductal carcinoma in situ, or DCIS. Masses are going to look similar to those that we find in cancer in females. And that means they're going to be spiculated, not circumscribed. They might have indistinct margins, and they're usually just slightly eccentric, unlike gynecomastia. So gynecomastia favors the subnipple area, perhaps slightly to the upper outer quadrant, and breast cancer can be a little bit farther out. All right, so here's an example of a 62-year-old who has invasive ductal cancer on the left. Here you see, this is the case I showed you before, which is not flame-shaped. This is a ball. This is clearly a mass, and it's dense. And sonographically, we see that it's very hypoechoic, and it has an indistinct margin, and it has some shadowing. So these are all classic features of malignancy. If this was a female, you would have no trouble making the diagnosis. You would recommend biopsy, and you would be doing the right thing. So this is classic appearance of cancer in a male. Incidentally, you can see just a tiny bit of gynecomastia on the right. And some pseudogynecomastia has a good amount of fatty tissue there. Here's a different patient, a 51-year-old with an invasive ductal carcinoma. He has an upper inner quadrant location, which is atypical for cancer and also not classic at all for gynecomastia. So you would never confuse this mass with gynecomastia. You would also go to ultrasound and see that this is a hypoechoic heterogeneous mass with a lobular contour here. Pretty typical looking for a cancer. If this was a female, you would have no trouble recommending a biopsy. You would assume this is a cancer and you would be correct. So you take the same approach in a male and you say, this has many suspicious features. I'm going to biopsy this. I'm worried this is a cancer. And it was. Here is another gentleman, a 58-year-old who has an invasive ductal carcinoma on the right. He also has moderate bilateral gynecomastia. You see here closer to the nipple, the flame shape density, which is gynecomastia. And then just a little farther out, we see this mass annotated by the triangle on the skin, which indicates where his palpable mass is. So it's important to correlate the physical findings with the imaging findings. When a man comes to us, it's usually because of a palpable mass, and we want to know, is he feeling all of this gynecomastia? Is it kind of a large, soft mass, or is it a small, harder lump like this, where there might be a cancer in addition to gynecomastia? And then we can confirm this sonographically. We see this hypoechoic mass with vascularity around it. We know we need to do a biopsy. These findings are suspicious, and we diagnose the cancer. Here is an older gentleman, an 83-year-old, who has invasive ductal carcinoma on the left and fairly marked gynecomastia on the right. But his palpable mass was not on the right, even though the finding here is larger, but on the left, because it's a smaller but harder mass and doesn't feel like breast tissue. If you were to examine him, you would feel a soft fullness on the right, and that would be the gynecomastia. But on the left, where he has much less gynecomastia, he has this smaller, dense, spiculated mass. Confirm it sonographically. You see a solid mass here with little spiculations. This patient clearly needs biopsy and has a breast cancer. Talking about breast cancer in the male, remember, males don't have lobules, so they don't get lobular breast cancer. Almost never. It's almost always ductal cancer, invasive ductal cancer. Occasionally, about 10% of the time, they can present with ductal carcinoma in situ, or DCIS, and usually it's a lot of DCIS if it presents clinically. There are enough ducts involved that there's actually a fullness in that area. But 90% of the time, the tumor is already going to be invasive. And again, it's because we don't do screening. We know that invasive ductal cancer has several subtypes, and all of the different subtypes have been reported, but the papillary type of carcinoma is the most common of the subtypes. The subtypes all being less common than the invasive ductal carcinoma not otherwise specified. So here's an example of the papillary type of invasive ductal cancer, a 68-year-old, and the intracystic papillary type is a kind of a classic appearance. Here you see mammographically the mass with convex contours, denser in the center, just like you'd notice in a female mass. Incidentally, a little bit of flame-shaped gynecomastia on both sides. But we take this patient to ultrasound and we see that there is largely cystic component of this mass. But on this septation, there's a lot of thickening, irregularly shaped mass along this septation, and a little bit of debris, which is probably a little bit of blood from some hemorrhage settling here. This is a classic appearance of an intracystic papillary cancer. So that's our module on types of breast cancers, and we'll get on with the next module in a short bit.